Good afternoon, Renew. How are you?
I'm good, thank you, Declan. It's good to be back here, and I love having guests in the studio.
Yeah, it's nice. I suppose this podcast started 4 years ago when we were all in total lockdown, and the only way we could reach out and meet people was on Zoom through the podcast. But now, physically, people are back in the studio.
And you know, when we were in the depths of lockdown, we did occasionally get the guest into our Peter Max studio. Do you remember that?
That's right.
We got one of them returning.
Yeah, hopped on his bicycle and cycled in through all the perimeter.
Wondered where to park his bike, and we didn't know. And
that's right. And he's back with us today.
He's back with us today. It's
Andrew Weickhardt. We'll reintroduce Andrew in a minute, but thank you, Andrew, again for coming back to see us. Today is an exciting one because we have an international guest in town.
We do. It's a big day. It's a big week. Every time we have an international guest, and this is a great one.
Yeah. So it's a great privilege to welcome Dr. Enrique Grande from the MD Anderson Cancer Center in Madrid, no less, who's in Australia this week. Enrique, thanks very much for popping into GUcast while you're down in Australia.
I'm delighted to be here.
And it's your first trip to Australia. How have you liked it so far?
I love the country, I love the people, and even I love the urologist.
We know already. Wow. There we go. That's
he said that in a whisper.
Yeah, but look, we better reintroduce Andrew, and he's going to, I'm sure, follow up with even more love for all his urology colleagues.
Absolutely.
Andrew Weickhardt, Associate Professor Andrew Weickhardt from here in Melbourne. He's a GU medical oncologist, specialising quite a bit in urothelial cancer, I think, within his GU oncology repertoire. And you're working at Austin Health and the Olivia Newton-John Cancer Centre, and friend of the podcast, cycled into the studio before. So, Andrew, welcome back. Good to see you.
Thanks so much for having me here. It's super exciting to be back in the studio with a great guest, and I can't wait to get stuck into it and chew the fat on bladder cancer.
On bladder cancer. So here
and
we
last
go.
time you were with us on the podcast, and this was at our Peter Max studio, we talked about Javelin 100. Maintenance of Velamab for metastatic urothelial cancer, and that's kind of become standard of care now, hasn't it?
And we're going to get onto that one as well today, but before we do, so what we're going to do today is cover urothelial cancer with these expert GU medical oncologists, and it's been a really exciting couple of years which we want to dive into. We want to dive into state-of-the-art treatments for second-line metastatic cancer, so patients who've failed chemo or ineligible for chemo, first-line metastatic cancer, and also we want to revisit the avelumab stuff. So what about patients who've had chemo, they seem to be doing okay, so adjuvant treatments, and we'll get to that in a minute. But before we do, we also want to do a shout out, as we do from time to time, to all of our wonderful partners who support GUcast.
This wouldn't happen without their support, so it's wonderful to have them on board, and we've had some great themed podcasts because of this partnership.
Yeah, so the partner program enables us to create all this content, and we've hugely increased the amount of content we can put out. Some might argue that's not a good thing, Declan, but anyway, we are putting out a lot of content. We have a lot more viewers and listeners, and it's thanks to the support we have. So our gold partners, Janssen Oncology, Mundi Pharma, and Bayer in China, who just came on board this year because we are starting some themed podcasts for our Chinese audience as well. Our silver supporters, Bayer, here in Australia, and we've pushed out a couple of really good podcasts on non-metastatic CRPC and metastatic hormone-sensitive prostate cancer with their support. MSD, who've supported us from the very start and who clearly have an interest in this metastatic space. Device Technologies, who roll out the Da Vinci surgical system here in Australia, because lots of our audience are surgeons, of course, so thank you to all of them. And our bronze sponsors, Cipla, who look after ADT here in Australia. They look after Degarelix in particular. Ipsen Pharmaceuticals, who have interests in ADT and cabozantinib, of course, and very recently, Rigicon, our brand new partners. They make a wonderful artificial urinary sphincter that helps a lot of our patients who've had prostate cancer and have stress urinary incontinence. So it's fantastic to have them on board. So it's GUcast family. It is a great mixture. It's GU medical oncology companies, it's surgical companies, and we're soon to announce a radiation oncology company, because we talk a lot about radiation on this podcast.
We do quite a bit.
And finally, I'll just mention that Bayer China also specifically support our conference highlights. So we've just pushed out the USANS highlights this week.
That's right, yes.
And we've had the ASCO GU
highlights, and we'll be getting Professor Zhu over for the prostate preceptorship soon.
That's right.
So Bayer China, huge.
So thank you to all those partners. So having done that bit, and you can read all about them on our website, or look for our themed episodes on the website. Let's get back into Let's get stuck into it, as Andrew said. Bladder cancer.
Declan, you were at ESMO this year, last year rather,
yes.
and it was huge for bladder cancer, right? Because there was not one but two trials that read out that showed in the first line setting that showed an OS benefit. For one was Checkmate 901, which was gemcitabine and nivolumab combination in the first line setting. And then, of course, EV302, EV Pembro combination, the first non-chemotherapeutic agent to show an OS benefit in the first line setting.
And it was kind of nuts. I'm suppose maybe we'll kick off and talk about that. But ESMO Medical Oncology Conference, I don't know, 25, 30,000 people. Standing ovation when Tom Powell shows the... It was like a concert. It was like Taylor Swift, except it was Tom Powell standing up there, and he's showing the OS curves and spontaneous...
he does have a bit of a rock star personality. I mean, I feel like he was pretty happy with that.
Yeah, he groomed it a little bit as well. He is an expert communicator, but maybe that's what we talk about first, because we want to talk about these new options in metastatic urothelial cancer, Enrique. And some of that story is about this drug called EV, as you shorten it to, enfortumab vedotin. And that's what got all those headlines at ESMO this year when they reported it in the first line setting. And you have a lot of experience with this drug, but could we start by going to one stage later, the data that came out a couple of years prior to show that this drug EV has real clinical utility in the second line setting? And because we have a real mixed audience, can you tell us what is this EV? Can you dumb it down and explain to us?
Well, I think this new family of drugs, the antibody drug conjugates, are extremely exciting, promising, not only in the GU field, but they are standard of care in prostate cancer, for instance. How do they work? They are like Trojan horses. Trojan horses because you have an antibody with like two hands. In one hand, they are binding to the tumor cell. At this case, enfortumab vedotin is binding to the Nectin-4, a transmembrane protein of the bladder cancer cells. So in one hand, they are binding to that. And in the other hand, they are bringing with them chemotherapy, a payload, which is chemotherapy, a kind of taxanes. So why these are like Trojan horses? It's because the cell believes this is a good thing for them. They internalize the antibody inside, and once the antibody is inside, they release the payload. They release the chemotherapy inside the tumor cell. So this is how they work.
It's a form of targeted therapy, really.
Yeah. I mean, I would say, though, we need to be careful that we don't fall for the branding and say that this is not chemotherapy to draw back, because the description is correct in how it works, but from a side effect profile, which we'll talk about more, it's simpler and probably more accurate to describe it to patients as smart chemotherapy rather than targeted therapy, because I think that kind of denotes the side effect profile. Would you agree?
It's like a posh chemotherapy,
Yeah, it's posh. It's a big area of research in oncology, and I think it's the way to go. And lots of different tumor types now are exploring these antibody drug conjugates. And so I think the development in bladder cancer has been fantastic. What remind us, though, the target? What's the enfortumab target?
Nectin-4? Yeah. Nectin-4 is a transmembrane protein. This is like a receptor, a transmembrane receptor, but this is a protein. This is just a protein on the cell surface that the antibody can bind it. But this is only the target. So this is not how it works. This is just targeting the cell. At the end, the chemotherapy the antibody is bringing is linked to the payload, is the one that is acting. So at the end, this is chemotherapy that you are delivering.
So for us prostate cancer nerds, it kind of sounds familiar. It sounds like lutetium PSMA. Instead of a radioisotope, you've got the payload, which is the chemotherapy drug, and instead of a PSMA targeting ligand, you've got this antibody that targets Nectin-4.
I was in the operating room with Renew earlier, and I was like, can you understand this EV thing just before we get on the podcast with these smart medical oncologists?
I said, Declan, of course.
She said, a bit like lutetium PSMA. I'm sure she was dumbing it down for my benefit, but we sometimes explain that like that. Okay, PSMA, we know it's a great target, and we've got these beautiful imaging things, and this is a way of bringing the payload, the lutetium, to it. And Is it ridiculous to think of an analogy like that for us simple urologists?
Not at all. Not at all. I think the concept is exactly the same. One is bringing radiotherapy to the tumor cell, and the other one is bringing chemotherapy to the tumor cell.
But the side effect profile is different.
Right, and because Nectin-4 is expressed in different normal tissues, such as skin,
of course,
skin rash is an issue with enfortumab, and the chemotherapy payload is a microtubule disruptor. It's very potent, and so we see neuropathy as well related to the side effect. So again, it's not quite the chemotherapy is just released within the cancer cell. That would be fantastic if we're able to really localize just the chemotherapy disruption within the cancer cell. But there are some of these side effects related to distribution and binding of the drug elsewhere.
Yeah.
Okay, so we've learned a bit about what it is now. Yeah. So, and thank you for that explanation. But can we go back then to when it first, I suppose, got your interest as having real clinical utility in
how
urothelial
it's
cancer?
Sort of evolved since then.
And how it's moved since then, because this is all really the last just 3 or 4 years, isn't it?
Well, the first phase 3 trial, the trial that gave the first approval for enfortumab in advanced urothelial tumors, is the EV301. EV301 recruited patients with advanced metastatic urothelial tumors refractory to platinum and immunotherapy. And it was very straightforward, the design. Head-to-head comparison, enfortumab vedotin versus the choice of chemotherapy of the investigator. Paclitaxel single agent, docetaxel single agent, or bimflunin at that time. Overall survival was the primary endpoint, and it was met. Hazard ratio 0.7, 13 months versus 9 months. I know that for you, the urologist, is not that much, but I think it is.
Some of these are
clinically significant improvement.
And I think,
and these patients had all progressed on everything, Andrew. Right? These folk had chemo, they'd had immunotherapy, modern agents.
Yes,
so
these are all patients that
8 to 9 months survival.
Pembrolizumab or avelumab in the past. So these were heart sink patients when they would come and see you, and they often had symptoms from bone or visceral metastatic disease. To be clear, a lot of those patients we can't treat with either agent because they're too frail and unwell. But it was a great leap forward given the higher response rates with this drug, the responses that you see in visceral metastatic sites, the responses that are durable, unlike chemotherapy when you see responses. So it is quite rewarding when you see some improvements in pain and function as a result of using the EV in that setting, right?
If you ask me, why you want to have enfortumab vedotin in your office, in your clinic, why it is important for the patient, this is exactly what Andrew just said. When you have a patient that is progressing, when the tumor, is progressing to platinum and immunotherapy, you need something potent, something that can overcome the resistance, something that can control the tumor growth, something that can induce a rapid and a deep tumor shrinkage in the metastases to control the symptoms, to improve the quality of life. And definitely enfortumab vedotin is contributing to that goal.
Absolutely. And I mean, as we can see in these other trials, it definitely has this anti-cancer, this potent anti-cancer effect. So now we bring it all the way into the first line setting with this EV302 trial. And, not only does it show this amazing OS benefit, I mean, what was it, Declan? It was like doubling of the OS benefit.
And so this was patients newly diagnosed with metastatic urothelial cancer who usually would have chemo or IO.
Yeah, we would normally treat these patients with 4 to 6 cycles of platinum-based chemotherapy would be standard worldwide. And many of these patients now, after that period of induction chemotherapy, would receive maintenance avelumab afterwards. But when the trial was first designed, having 4 to 6 cycles of platinum chemotherapy and then a period of observation was standard. And so this EV302 study sort of built on that combination of EV plus pembrolizumab, bringing immunotherapy into the front line. Let me ask you a question. Were you confident that it was going to be a positive trial, or did you feel that this was going to be a winner when you...
EV Pembro?
Yeah.
I think this is the winner. Despite
Did you expect it though?
Yes, for sure.
Yeah.
Yeah. I don't have any doubt.
Yeah. We had it at our centre, and we had a few patients that went on that combination. And once they had a response, and the response rate was very high in the EV302 arm, the responses were very durable.
Yeah.
So you would see patients 2 to 3 years later without tumour progression. And it's very different from using chemotherapy, which gets, I guess, to the question, do you think there's synergy between the EV and the immunotherapy? Is that what you think is going on here?
Two things. In the past, we were considering that metastatic urothelial tumors were chemosensitive, particularly platinum sensitive. And this is one thing, this is one statement that, in my opinion, we shouldn't consider anymore. Why is that? It's because of the Javelin bladder data. In the Javelin bladder, in the control arm, we were using those patients who were the best for chemotherapy, the ones that were responding to the induction chemo. The median progression-free survival in the control arm, those patients who responded to induction chemo and they were just observed after that, it was only 2.1 months.
Yeah, it's crazy.
So it means that chemotherapy is active in terms of reducing the size of the tumor, but the responses are not durable at all. So this is exactly the change that we were waiting for. Now we have the option to offer for more responses, but the most important thing, more durable. So this is what we really wanted.
Do you think the immunotherapy component is what's giving the durability?
This is synergism.
Okay.
For me, there is a kind of synergism. If you sum up the percentage of patients that are responding to single agent EV is around 40-45%. If you sum up to 20% of the responders to Pembro, you can say, okay, this is about 60-something percent. Okay, same amount. But this is not true at all, because those patients responding to chemo traditionally are the same patient profile that are responding to immuno. To have a phase 3 trial in which two-thirds of the patients, they are reaching a RECIST response, I think this is something more than additive. This is something more synergistic.
And I guess for our urology colleagues who are smart in many ways, but they I think it's worth putting into perspective that there have been trials of chemotherapy with immunotherapy in the front line of treating patients with metastatic bladder cancer compared to chemotherapy alone. So this combination of immune therapy with something else has been trialled, and it didn't seem to offer with chemotherapy any additive synergistic benefit. And those trials, apart from Checkmate 901, which we can touch on in a bit, I mean, those trials were all universally negative. And the EV and Pembro is probably synergistic, and perhaps that's related to neoantigen exposure or some other mechanism. But it really has transformed how we think that patients should be treated in the first line with metastatic bladder cancer. But I guess the relevant question for the audience is, who do you think is eligible for EV plus Pembro in the first line? Are all our patients eligible? Do you have an idea which patients you wouldn't treat with that combination?
Do we need ineligibility criteria for Cabo-Nivo in kidney cancer in first line? Do we need ineligibility criteria for lutetium PSMA in prostate cancer? Do we need ineligibility criteria for enzalutamide in prostate cancer? The concept of ineligibility is very linked to the metastatic urothelial field because of cisplatin.
Right.
But I wouldn't say loudly, but do you really think that we should still consider Galsky criteria to classify patients in advanced urothelial tumors?
Those criteria were set up in the platinum era, where the guidelines might suggest whether or not patients should receive cisplatin or carboplatin. But your argument would be that we don't need to necessarily restrict the use of enfortumab. But I think it's fair to say that in EV302, there were very few patients that were ECOG performance status 2. Although it technically did allow recruitment of that patient population, if you have a look, there was sort of complicated reasons, but there was only 1 or 2% of patients who were, borderline for treatment. So what we don't know about the results, I think you would agree, is that does this translate to the real world where patients are 85 who are a little frailer?
I understand, Andrew, but using the Galsky criteria, whether we like it or not, but using the Galsky criteria, those patients eligible and ineligible to receive cisplatin, the hazard ratio for survival was exactly the same.
Yes.
So this is not easy from the clinical perspective to identify patients that are not eligible for enfortumab vedotin. Which one they are? Well, you need to use the common sense. And the common sense, if you have a drug that is giving hyperglycemia, retinopathy, or at least blurred vision, neuropathy. So it seems that diabetic patients, uncontrolled diabetic patients, could be not the ideal patients for these new drugs.
Right. So the overweight patients who haven't checked their blood sugar, we would always check a blood sugar before using this drug. And I think patients with pre-existing neuropathy and numbness, that definitely will get worse if you use this drug after several months. In fact, most patients after 6 to 12 months are going to start to get numbness in their fingertips, and that leads to dose reductions. And
so that's the next question then, Andrew. How long do you give this treatment for? I mean, how many cycles of EV do you need? Do you stop it at a certain point in time? How do you make those decisions?
How would you use it? I mean, conventionally in the trial, it was begin the treatment with pembrolizumab in the first line and continue treatment, reducing dose if there's toxicity. If you look at the trial, the median duration of treatment in patients that were responding, so receiving active treatment, was about 12 months. So it tells you that although patients were still responding and the median duration of response was a lot longer than 12 months, right? That a lot of those patients had to stop because of the cumulative neuropathy. So I think there's still work to be done, and I'd be interested to see what your thoughts are and how you would explore this, right, in the optimum dosing strategy to allow ongoing use, or whether or not you just need to give induction treatment and then re-challenge. Some of these ideas are being floated.
This is what we call the de-escalation trial. So maybe we can start with EV-Pembro, with the combo, give for 3-4 cycles, something like that, stop EV, maintain Pembro, and if the tumor relapse, reintroduce EV again. So this kind of a strategy could be a smart one.
Freaking fantastic, isn't it?
And yeah, I mean,
because these patients, you're thinking, all right, cumulative, it's 12 months, Andrew, and they get a bit of neuropathy. A lot of these patients would normally be dead by then if they'd had some chemo.
Right.
I suppose there's a big trade-off because it's such a lethal condition when you're diagnosed with metastatic urothelial cancer that you're, unlike in, say, the adjuvant renal setting where you're going to live a long time, or lots of people don't need treatment. In this setting, people are clearly at very high risk of progression and terrible morbidity and death. So there's a certain threshold, I'd say, for tolerating certain predictable toxicities.
Right. So the EV301 study, we were talking about the difference in survival, and the median survival was, just over 1 year median survival for the EV treated group. The impact of neuropathy on your life, if you have that median survival, is not the same as now if you're using the drug in the first line. And some of the patients I've looked after that I've used it in the first line, they're still responding. Their cancer is under control 2.5 to 3 years down the line. And you see this in these long-term responders. But all of them now have quality of life issues related to neuropathy. So I think that is the next step with this drug, is to try and work out how to optimize its use.
And biomarkers.
Yes.
If we are able to predict the activity.
What is the biomarker story with EV?
No one.
None.
It's because, the expression of Nectin-4 in the primary tumor probably is not reflecting the reality of the metastatic tissue. So we still have a lot of work to do in terms of biomarkers. And the question, Declan, is the resistance to enfortumab vedotin, the resistance to any antibody drug conjugates, is driven because of the target, Nectin-4, or it is mediated because of the resistance to the payload, to the chemotherapy. We still don't know about that.
So I was making a joke about their intelligence before, but they are clever urologists that understand about.
It just went straight over my head.
They're probably familiar and aware of other targeted therapies such as FGFR inhibitors in bladder cancer, which is a relevant target. And we were talking before about 20 to 30% of patients may have mutations or amplifications. So here's a question for you. In patients that receive standard chemotherapy and immune therapy, some years ago, but now have relapsed and progressed, that would qualify for enfortumab vedotin as it's labeled EV301, but they have an FGFR mutation. What would you use? Is there data to guide us clinicians in whether or not we should be using the targeted therapy of the FGFR inhibitor or the enfortumab?
I don't think there are major differences in terms of potency, in terms of activity between enfortumab vedotin and erdafitinib. I don't see any major differences. I see differences in terms of the tolerability. Safety profile is completely different. You need to, and depending on the patients you have in front of, maybe erdafitinib can be tough in terms of tolerability. But if you are doing the effort to identify molecularly the patient, I am putting ahead erdafitinib of enfortumab in the sequential treatment strategy. But I feel happy by using any one of them.
There are some patient factors too here because and choices because erdafitinib is an oral tablet, and if you live 2 hours from an infusion center, that could be particularly advantageous to your quality of life, whereas enfortumab is a weekly dosing for 3 weeks when it's used as a monotherapy, followed by 1 week off. That's quite a lot of trips for some people into an infusion center.
Probably in Australia, this is something that you should take care about. In a country, in a small country like Spain. I don't know how many Spains can be fit in Australia, but probably more than 10.
So what if this now becomes a new standard of care as first-line treatment for metastatic urothelial cancer and patients progress after this? What is your next option? Would you then be testing for mutations like FGFR, or would you be going to chemotherapy? What
something much less attractive? Carbogem.
Okay.
Carbogem is considered the standard of care after EV Pembro.
Yeah,
and of course you should test.
I think we would still resort back to platinum-based chemotherapy. But I think that's an area that's ripe for clinical trials, whether or not those patients that had FGFR mutations, for instance, might have a preferential treatment with targeted therapy rather than chemo. But it does seem to still be active platinum-based chemotherapy after EV Pembro.
And what's the current story in Australia from a reimbursement point of view? Of course, this data is all new. EV Pembro is not even published yet. Tom told us it's coming imminently, but what do we have access to in Australia?
Yeah, so the good news for us here in Australia is on October last year, we got access to enfortumab in the third-line setting, so based on the EV301 data, and that allows us to use the treatment in patients who've had previous chemotherapy, prior immunotherapy, and the use is currently restricted to that. Ideally, we would like to use the EV pembrolizumab combination upfront. There is a clinical trial, an umbrella trial that's running at our centre, for instance, that in the first line is using the EV pembrolizumab plus some additional immune stimulating medication. So these companies are now trying to build on that as a backbone, recognising that is the standard of care. Yeah.
And Enrique, is there a difference in prognosis or your choice of treatment if patients present with metastatic UC as opposed to patients who've had localised disease in the past and then have had a relapse and developed metastatic disease?
Well, around 10% of the patients are initially diagnosed with metastasis. Probably the prognosis is worse. Probably it is, as it happens in prostate cancer. But I in any case, this is a debusting and a very aggressive prognosis from the beginning if you have metastasis.
It's just a bad disease.
Have you learned a bit about bladder cancer?
I've learned so much. It's been incredible.
It's been great. And on this podcast, our bladder cancer episodes consistently attract huge audiences, anytime bladder cancer. So we hope all of you loyal GUcast listeners and viewers enjoyed that masterclass.
And two greats of
two greats,
joining us
absolutely.
in the studio.
Masterclass in the management of advanced cancer. We didn't talk much about maintenance, etc. But look, I love the idea that for bladder cancer, we're going to have to talk about it more and more often. We're doing it in the journals. conference as well.
Absolutely. And bladder cancer is this amazing field. I mean, we talked about Javelin 100 a few years ago, Andrew, and now it sounds like that's become standard of care, in just 3 short years. And then, there was a bit of a paucity of data, and now we've got these amazing trials that have shown OS benefit in 2S.
And nothing for the previous 20, 30 years.
So it's just such a
dramatically changing
field.
And the neoadjuvant studies of some of these combinations compared to neoadjuvant chemotherapy will be reported in the coming few years, and it again could change completely. So it's exciting times, isn't it, Enrique?
And we don't have time, but I'm gonna be provocative because you cannot respond to me, okay? But do you think, Andrew, with these new, very active, very potent, very rapid drugs that we have, combos that we have, do you think there is room for surgery in the muscle-invasive tumors?
Wow. I mean, between you and me, if I had a complete response.
We didn't prep him for that.
We've taken over.
We don't have time.
He said he was friendly with urologists. As soon as they see the end inside on the podcast, they land a punch. Yeah, look,
that was fun.
Great. Actually, but on that, are there neoadjuvant EV studies?
Of course.
Okay,
of course. There are a couple of trials testing EV versus chemotherapy in patients eligible for cisplatin and versus cystectomy.
No,
in patients ineligible.
Not prior to, okay. It's all right, we're used to it. Urologists are the masters of reinvention. Every time we're threatened by something, for example, active surveillance, so we don't operate on
don't worry.
we operate on metastatic cancer.
Bladder preservation means that you'll do indefinite, lifelong cystoscopies for every 3 months, so you'll be fine.
And lifelong podcasts, definitely.
We'll always have something
content creation.
There's nothing to do in the operating room.
Exactly.
Well, look, that was really, really enjoyable, I have to say. Very educational. I hope you enjoyed that. And great to have Enrique in town, and you're doing a big speaker dinner tonight. There'll be a really big crowd, we know, coming. Everyone interested in bladder cancer here to listen to Enrique in town tonight. And Andrew, thank you so much again for giving up your time and coming in here and educating us. And great to have you back in the studio.
It's been a pleasure.
Thank you so much.
Thank you.
Renu, that's all we have time for.
Sadly.
What else have we got coming up? We recorded a bunch of episodes in the past few weeks, actually.
We have,
We had a few other speakers in town. Axel Mercerberger did a podcast with us. Neil Fleshner did a fantastic podcast. A bit about prostate cancer, a lot about entrepreneurship for a guy who just recently sold off his company for $1.4 billion US. So the
he
Neil
says anyone can do it.
Anyone can do
it.
So that's coming up very soon. And we'll be back with you shortly. Thank you so much again.
Bye-bye.